very warm welcome to one of the 2021 Brain Forums here in Zurich. My name is Margrit Leuthold. I'm the moderator of today's session about health sector digitalization. It's time for action. What's holding us back? The theme is not new, but it's still burning. And we know that digital health tools have the vast potential to improve our ability to accurately diagnose, monitor, and treat diseases, and to enhance the delivery of healthcare to the individual. The benefits which are propagated should be obvious. We want to reduce inefficiencies. We want to improve access, also in remote areas, reduce costs, increase quality, and make medicine more personalized for patients. So the question of today's forum is more than obvious. What is holding us back? A Forbes report from 2016 says that among 20 different sectors, healthcare ranks at number 17. So it's kind of scary because health is precious. Health affects everybody from us. So I'm very happy to introduce you to today's panel. Most of them are Swiss, and we will also have a great speaker from Canada, which I'll introduce in a minute. I start with our physician today, Thomas Grunwald. He's a neurologist and was, until February 2021, the medical director of the Swiss Epilepsy Clinic here in Zurich. After his retirement in February, he has founded the Zurich Epilepsy Institute and works as an epileptology consultant in different areas in Switzerland. Just to the left of me is Ernst Haven. Ernst is a professor at the Institute of Molecular Systems Biology at the Swiss Federal Institute of Technology, ETH. In 2012, he acted as a founding member of the association Data and Health and co-founded in the same year the non-profit health data cooperative MyData in Switzerland. Ernst Haven also serves as the president of the Biotech Park in Zurich. Then we have Teresa Solfrank in the middle. Welcome, Teresa. She is a natural scientist with a strong background in neurology and currently Chief Product Officer at NeuroPro, a Swiss-based company founded in 2012, and we will learn a bit later what the company does. Last but not least, a very warm welcome to Toronto, Canada, Sean Hill. Sean is the inaugural director at the Krembil Center for Neuroinformatics, senior scientist at the Center for Addiction and Mental Health, and a professor of psychiatry at the University of Toronto, and holds a PhD from Switzerland in computational neuroscience. Very warm welcome, Sean, and thanks for getting up so early for our debate. Okay.
My pleasure. Thank you for having me.
Before we go into a deeper discussion, we would like to hear something from the practice. So Thomas Grunwald kindly will share with us in the next couple of minutes an example from 2021, how it works. Thomas, the floor is yours.
Thank you, Margaret. I'd like to tell you about an example of everyday neurological practice that I find annoying. You said that I'm a neurologist and I specialize in epileptology. That means my task is to treat patients who suffer from epilepsy, but also to exclude epilepsy in persons who do not suffer from epilepsy, if this is possible at all. Something that's quite common in everyday medical practice is the so-called blackout. That's, in medical terms, spontaneous transient loss of consciousness followed by complete recovery. That's quite common, actually. The National Institute for Health and Care Excellence in the United Kingdom has published their guidelines in 2010, and they estimate that up to 50% of the population of an age above 16 suffers from a single or more blackouts once during or twice during their lifetimes. So that's a very common event for people, and it can have many different causes. Some of them are harmless, and some of them even can be dangerous. So it's necessary to try to find out what the reason for such a blackout or transient loss of consciousness is. The normal medical workup includes, for example, history taking, of course, the physical examination, cardiological examinations, medical imaging like MRI, for example, but also in a few cases recording an EEG. The EEG, the electroencephalogram, is the recording of brain electrical activity. And in these recordings, we look for so-called epileptiform potentials. These are certain waveforms that are typical for patients with epilepsy. The problem is that these typical waveforms are biological data, and biological data, unfortunately, do not always adhere to textbook definitions. So sometimes it's quite difficult to classify them as either epileptogenic or epileptiform or not epileptiform. So time and again, I meet a patient who has suffered a blackout, and I suspect that she did not experience an epileptic seizure, but she was fainting. But some colleague may have recorded an EEG, and in his report he describes some potentials that are, quotation marks, suspicious of epilepsy, whatever this is. So this suspicion of epileptiform potentials also says that there's a suspicion of epilepsy, which means that this patient that I met last week actually, was another example, is not allowed to drive. So normally I will ask the colleague to send me the data or to give me access to his data so that we can discuss it and check again whether this was really epileptiform or something else. It will usually take some time until my request reaches the desktop or the attention of the colleague, who eventually will decide that he will comply to my request and then ask an assistant to burn a CD-ROM for me with the EEG data, which he then posts to me. And I will receive it a few days later and will find that I cannot read the EEG data because they have been recorded in a data format that my EEG reader cannot handle. So I have to contact him again and ask him to burn another CD-ROM with an EEG reader that can handle these data so that I can have a look at it. And when this CD-ROM reaches me eventually, I may find that the so-called potential suspicious of epilepsy was a normal variant after all, so there's no suspicion of epilepsy. Of course, this may then be too late because meanwhile the patient, who may have been a bus driver or a sales representative or had some other job that requires a driving license, has lost his job together with the driving license. So even if I say now it's no epilepsy, I'm too late and there are social consequences. This is really annoying, and it could be avoided if we could share data and not only reports on the data. So can you help me to improve this in the future?
Thanks a lot, Thomas Grunwald, for this intriguing example in the 21st century. We all think sometimes we should have overcome this, we should have been further advanced, but obviously in practice it's not. All three other panelists have different approaches to find solutions, and would like to ask them one after the other to very quickly present your business ideas, your models, how to make data more interoperable, how to overcome this shortage described very lively by Thomas Grunwald, which I'm sure you're not the only physician who faces such challenges. This must be the norm still today, at least in Switzerland. So Teresa Solfrank, NeuroPro is currently developing a data sharing platform to overcome exactly these shortcomings. Can you describe in a nutshell the idea behind it, how it works, and who could finally use it?
Sure. So yeah, what NeuroPro came up with is like a remote diagnostics and collaboration platform, especially for, let's say, complex medical cases and especially for brain diseases. And in a nutshell, it should make the whole process much more easier to share medical data between physicians, between institutes. And as Thomas Grunwald already described it quite clearly, I mean, the problem that we are facing at the moment in the hospital is each hospital has their own recording system. And in the end of the day, they just have this huge pile of data in different formats. And until today, it's just not possible to share these data really in a, let's say, efficient way, not with via mail. So yeah, what our software actually does, or our platform, is we can transform these different kind of data formats into one universal format. And in the end, that's really easy to share. But we don't want to be like a second Dropbox where you can just upload data, send a link, and someone downloads the data. We actually have the feature of a real data viewer. And I think that's a big difference. We can actually, you can open an EEG file, you can have a look on the signals, and also you can collaborate on these, like single copy of this file with another physician. Yeah, this can be done from anywhere at any time. And I mean, I believe this will not only like change the way that physicians or neurologists work with each other today, but also offers like a big opportunity for remote diagnostics. So I mean, if it's that simple to share data, it's also that easy to get like a second opinion, or also to work as like a team of healthcare professionals on let's say complex medical case. And this is then like independent on in which hospital you are, or even like in which country you at. And I think that's the big beauty of our product really, is that it creates this like healthcare network. It's a global network, and in the end, we really hope it's the patient in the end who gets like the best possible treatment and service, medical service. And yeah, I mean, for us, we started this project like 5 years ago, and we are now luckily in a deployment phase. So we have 4 clinics here in Switzerland using the software at the moment, and 5 more to join during the next weeks. It's exciting times. But yeah, I mean, all of you, I think, would agree the healthcare sector is highly regulated. It was a bumpy road to actually get to this point. And I think just one thing to mention from my side, what was really important for us was to gain the trust of the hospitals that we are implementing this software in. And also during the whole development process, it was so valuable to get their input and to have them on board and really help us in developing that product.
Okay, excellent. Thanks a lot for sharing, Teresa. We will definitely come in a later stage also to costs and the trust building. I think these are very essential parts. But before that, I would like to switch to Sean. Sean, I think you are implementing interoperability of data maybe in a slightly larger scale. As I understood, you managed at the CAMH to set up a platform where data can be shared also beyond a certain specific area. Can you elaborate a bit what you exactly built here in Toronto and how it works, and what's the secret for your success?
So thank you. First of all, we're dealing with a really hard problem, which is mental health and mental health diagnosis and treatment. And one of the big challenges is that we don't have consistent mechanisms to diagnose. We've got the DSM-5, but there's a lot of subjectivity to the way that that's used to diagnose mental illnesses. And we're lacking consistent data that shows for an individual what the history is and what the longitudinal perspective is for how their mental illness has developed and evolved. So, of course, data science and having the opportunity to have data and using AI to detect patterns seems like a really great opportunity, right? It's be phenomenal to be able to apply that. But as you probably know, the electronic health record systems, even if you have an electronic health record system implemented in a hospital, there's no guarantee that the data in that system is actually usable for AI and machine learning and predictions and easily shareable, because of data governance, but also because of the way that system, these systems, which are global, there's the big players that have built these systems. They built them for administrative tracking. They didn't build them for high quality data. They didn't build them to implement machine learning and analytics. So there's a big gap between what these electronic health record systems were built for and what they actually deliver. So what we've done with the CAMH Brain Health Data Bank was to collaborate closely with clinicians and to collaborate closely with patient and family members on what would be valuable to them in terms of seeing data and using data in treatment of a patient or in their own treatment. And understanding their needs and the value, what we did is we extract out of the EHR system, the electronic health record system, all the data, and in particular, the data that's useful for these decision support charts. And we store that in an interoperable knowledge graph, which is basically, it's a complex database that organizes the data so we can search in many possible ways and we can apply machine learning. And we built that off of the international standard called FHIR, which is it's basically a global standard for interoperable sharing of medical records. So we use that to provide these tools to clinicians for decision support. And critical to all of this is having a clear data governance, a consent from the patient that their data can be shared, and having the hospital buy-in that this data can actually be shared with specific governance, clear terms in terms of who can access it and how to use it, how it can be used. And that's a big challenge. I think CAMH has done an amazing job sort of with top-down leadership to say this is important for the betterment of our patients, but it still remains a big challenge.
Thanks a lot, Sean. Can the data leave the hospital, or are you not that far yet?
So we have recently received approval for, now the way we've done this is as a research study that includes the clinical records. So we basically, the patient consents, if they participate in this study, they consent to allow the usage of their clinical data in combination with the research data to be anonymized. So it's no longer recognizable as that individuals and shared. And what we do is we maintain an encrypted identifier. So clinicians, if they need to, can identify who it was because they have the lookup between this identifier and the actual patient, but nobody else does. And so with this study, we are able to collect data that can be shared beyond the hospital walls, but it does require that patient consent.
Thank you very much. I turn to Ernst Haven. You are a strong advocate of patients who should own and manage their health data and have therefore built this non-profit health data cooperative, My Data, some years ago. Can you present a little bit the idea of My Data, or in general about, this ownership of the data by the patients and how this could work and should work?
I think we've already heard two solutions that go towards the digitization of health record and the usefulness of it. We heard from Teresa, a system where data can be shared between different hospitals and doctors, and we heard from Sean just now how data can be actually used for research once it is standardized and made interoperable. None of these solutions necessarily solves Thomas's problems that he mentioned at the start. Actually, I think the problem would have been solved if you had lived in the former Soviet Union, because I was told that their patients just received a booklet and every doctor just wrote everything into this booklet, and it actually moved with the patient from doctor to doctor. So if your patient had this booklet, you would have access to the EKG, etc. So that actually goes back to the power of the individual to have data aggregated. Because it is, for me, it would be useful to have all my data in one place on my smartphone. Because remind you, it has taken just 14 years since the introduction of smartphones that every one of us has one in his or her pocket. And we have used it without any parliament deciding whether one should allow smartphones or not. They are just here because they're extremely useful. So why not have on my smartphone my entire access to my medical record that I can share with an emergency room a doctor or with a doctor for a second opinion? I think this is even more important now that much of the health data that we can record now and in the future goes through the sensors in our smartphones. How we move, how we type, when we get up, etc. Blood glucose levels, heart rates, everything is monitored 24/7 on our smartphones. And these data will be increasingly more important, equally important than the medical data that we receive in the hospital. So, and it's only me who has the right to aggregate this data. So the Me Data Cooperative goes from the premise that we as individuals have a right to obtain all copies of all our data because the data can be copied. The hospital has to keep a record. Data is equally distributed amongst individuals. We're all billionaires in genome data, for example, whether we live in Tanzania or in Switzerland. And thirdly, we're the maximal aggregator. So we could actually build an own parallel data ecosystem that is actually governed by a cooperative that is owned by the citizens themselves. And then if this data is interoperable, like in Jean's case, we can manage it to give access to pharmaceutical companies to research of the anonymized form of the data, just as Jean described. And we would create this parallel data ecosystem where we are at the center, and that would give us a lot of new data services that we could pay for rather than giving the data away to Google and Facebook as we do now. So I think there is a great potential to change the digitization by putting it really into the hands of the individual, much in the same way that every one of us has a bank account. You know, the economy works because we all invest our money and spend our money differently. In much the same way, we could create such a health data economy where we are at the center. And that's the goal of the health data cooperative movement.
Thanks a lot, Ernst Haven. When we listen to each of you, it all sounds so reasonable, so common sense, and still in reality we face so many stumbling blocks. I would like to enlighten a few of them because it seems to me essential. One of them is this concept of who owns the data. When I look back in the Swiss history, and this debate is in Switzerland, so I think it's legitimized, you know, it was until very few years back that the hospital thought the data are owned by the physician, by the hospital. And only a legal framework then made it clear, but even that was for many lawyers not so clear, that the data should be and are owned by the patient, by the individual. And from that notion, even for example today, if you want as a patient your health data from a hospital or from a physician, if you are lucky, you get it immediately. If you are not lucky, you have to address several requests. They can take up to 1 month. That's the legal framework to give you the results or the data. Maybe until then your disease has already progressed or whatever. So it's from that perspective, I think, not patient-friendly, and this transition in the notion and the concept is still very strong. So Thomas, you as a practitioner, how do you see that? How do you live that in the hospital? What is your notion as a physician? Is it for you very clear that the patient owns the data, and would you agree happily to a concept provided by Ernst Haven?
I think we are experiencing a clash of cultures at the moment, and almost a revolution how we approach data. You know, when I studied medicine and when I was a young doctor, I was told by my elders that if my car broke down and I bring it to a repair shop, then I don't want to get a readout of the diagnostic machines. I want my car repaired. So that's the same with the hospital. And we have learned that, well, we were taught that there are only 2 reasons why somebody would want our data. Of course, we are the ones who own the data. The first reason is that they want to sue us, because people only want our data if we did something wrong, if there's a complication. So be aware if somebody asks for data, they're going to sue you. And the other is that they want to steal our data to do their own research. And we have to protect our data because we don't want it to be stolen. So that's what we have been used to think over the last decades, and it will take quite an effort to change. To really change this, I think we have to learn that we have some benefit from doing this. And this is also something which is not that easy to learn for young physicians, for example, because usually when we have a new software system installed in our clinics or practices, we learn that it does not help us reduce the work, but it increases the work, and we cannot really see where's the benefit for this. So as Anne said, the immediate benefit is something that we have to learn that there is something. And I think times are changing at the moment, and we have to learn that the patient is the one who owns his or her data, but it will still take some time if we have a really feeling that this is true.
Mm. Thank you, Thomas. Sean, you mentioned the importance of having the top people of the hospital behind you. Was this easy? I mean, was there an openness toward this concept that data should be shared, they should be there for the benefit of the larger public? Or how did you overcome this? Were you just lucky, or did you have a smart approach?
Well, in fact, when I was recruited to this position, it was to create a center for neuroinformatics inside of a hospital, which was quite unique. And I basically, spent quite a lot of time questioning exactly that. Is the leadership really behind this? Do they understand the complications of this, the challenges of this, the risks of this, how and the benefits? And it was really interesting because they were very clearly committed to this is important for our patients. And what was striking is that it's not only the top-down leadership, but it's the patients and family members that are engaged with the hospital, because they have a group of patients and family member advisors. And what they have been very clear about and very articulate about is if there's some benefit that my experience or data from my experience struggling with a mental illness can have a benefit and reduce the suffering of others, then I want that to happen. This is important. I want my data shared. I want this to benefit the broader community and the world. And so it needs to happen. And I think when that equation of who's going to benefit and do we put the benefit for the patients, as well as, in the end, streamlining if you make it better for the clinicians to be able to spend more time with their patients because the data is just there and easy to access, then it really is a win-win, as well as finally having the asset of data in a form where you can actually do something with it. And so I think it was striking. Top-down leadership, patient and family voices really driving this.
Thank you. You mentioned another very important aspect. I would call it the concept of this user-centric design, that you involve very early on the end users. And I think there is even today sometimes a lack in bringing in the end users, patients, caregivers early on. And I think, Teresa, if I understood correctly, this was also a part of your success story in NeuroPro. Can you elaborate a bit how you did it and how you consider the importance of it?
Exactly. I think the most important thing is really look closely on the problem you want to solve, and then you have to really understand what is actually the problem, who is having the problem, and really get in contact with them. So I think for us it was really important to go into the clinic, to talk to the clinicians there, to talk what problems they're facing, and really find a solution that either disrupts the whole way they're working or just fits in quite well in their actual work that they are doing. And I think it was mentioned before, it's when you come with a new software to a hospital, everyone is like, we don't need it, we don't want it. you have a lot of benefits with this software, but of course it needs effort and time to first learn how to use the software and then really get the best out of it. And I think that's something that is really for us as a software company, or that we want to have a solution, a digital solution for the clinics. You need to know the people who are using it and then really make something intuitive to use, so that it's not like a 1 month training necessary to actually use the software. And I think that was really important for us from the start, because otherwise it's like this solution that no one uses. And as Ernst also mentioned, I mean, you have to get out something that people want to use, and then it's going to be used. If you have to force them, I think there's not a good chance for you that you can survive.
Thomas Grunwald, is this in your practice, was this the rule the last decades when you were a physician in a hospital? Have you been involved early enough, or was sometimes a situation that you just received the software or whatever and didn't have a clue what to do with it? Or how is the reality there?
Depends on what kind of software. The problem is that in the beginning, nobody, or at least we as physicians, sometimes do not know whose problem the software is going to solve. For example, if it's just an administrative problem, but the physicians have to fill in forms, then we sometimes have difficult to understand what our benefit is. So it is more work, but maybe somebody from the administration is going to profit from it. So that's difficult. Maybe there's some misunderstandings in the beginning. Teresa's software is a little bit different, because we were involved in defining the problems that the software should solve right from the beginning. And I think this is a way that we have to start. In the beginning, we have to define what kind of problems the thing will solve and who is going to profit from it. And then we have to ask those people who should profit from this new solution, how they could do this. And I think even hospitals can profit from such data sharing, because if you share the data with your referrers, then they're more prone to send patients to you. So there's an immediate return on investment. But that's a new approach that I think we still have to learn to go.
I sometimes ask myself whether we are just too impatient, that this transition should happen much faster. But if you look at the reality, for example, in a clinic, I mean, you have your daily routine, which is, in my view, since decades more or less the same. Patients come to the hospital, you have to treat them, you have long working days. And then in addition, you should do this digital transformation and adopt all these technologies and, into your daily practice. In addition, at least in Switzerland, for example, in the general practitioners, we have the same number of physicians above 65, so above our retirement age, as we have below 45. So the digital natives just not even outweigh the digital non-natives, which are 65. So this is a reality. And then I think, if you have to adopt a new technology which you don't understand because you haven't been trained in it, maybe this is just a hurdle. We need to be more patient. What is your opinion about that? Are we pushing too far? Are we moving too far, leaving especially the physicians behind us? Or
I don't think so. I think even the physicians above 65 use WhatsApp and Facebook. And so I think the learning that we have is, if we want to promote this transformation, I think, as Sean said, I think including the patients and giving something immediate feedback to the patients back. This is the iPhone moment, I mean, why do we all have smartphones? Because they solved the problem we didn't know we had. We can connect, we can we can see where we are at the moment instantaneously. And this instant feedback, we're biological organisms. We are trained on personal feedback. And so the personal feedback that Facebook gives us, that WhatsApp gives us, is exactly what happens. And this is not something that is happening in the healthcare system, because the data is stored everywhere. Even if we get my blood readings, I cannot interpret it because it's not useful to me. If it would say, this is your average and your average age men have this and this reading, it would already be more explanatory. So there is a whole opportunity for data services that are focused on the individual, that will then also help. They have to be secure and they have to be fair, but they will also help the over 65 physicians that they don't have to use WhatsApp to communicate with their patients, but they can use a secure form to do that. And it helps them to be more efficient. And all the hospital systems and the electronic health records that we've seen are so clunky because they've been developed or designed 15 years ago, before the smartphone was invented. So I think having a user-centric design from the individual, from the healthy individual and from the patients, to give this sort of health graph from cradle to grave at your phone's disposal is one way to initiate that. Because we cannot go on like we've just done now.
I agree, yes. Yes, Thomas?
I would like to add another example. You mentioned this Russian booklet. I mean, that would be a first step, but I'm still not convinced that it will solve my problems, because maybe epilepsy is quite a typical kind of problem, a typical kind of disease that needs multimedial data, because we have the EEG, we have the imaging, but of course, and most importantly, we have videos of the seizures. So, for example, if patients have a small booklet, I was the patient, have a small booklet, and I show it to my wife, and it says, when your husband has a generalized tonic-clonic seizures that last more than 3 minutes, call the ambulance. And she might say, a general what? So how does this help? But if I have a handy mobile phone and can show her a video of one of my typical seizures and tell her, well, if I do this and this lasts longer than 3 minutes, then please call an ambulance, otherwise don't bother. So that would help. That would be an immediate help for me and a benefit for me. But if a company would like to provide an app with these videos, then they probably would not be allowed to do this, because even if the patient agrees to give their videos for this purpose, they would say that, well, it cannot become more personal. You can see your face on this video. You are not allowed to use this for our app. So there are always at first so many problems with laws and regulations that have to be solved that it's sometimes very tiresome to do this.
I would like to look a bit closer at this concept of trust, and you, Sean, mentioned it also, the importance of trust. And there is for me a very strange discrepancy of how generously we share our data when it comes to the use of social media, but there is this huge mistrust when it comes to personal health data. And for example, Denmark, who is among the most advanced countries in Europe when it comes to digital patient records and digitalization in the healthcare system, they argue that there is a lot of trust into the general practitioners, historically grown, and that's why it has been quite easy to adopt it on a national level. So, have you any explanation why we have this deep mistrust, and maybe a recipes to overcome it? Maybe Ernst, you probably must have dealt with it when you set up My Data.
Yeah, I mean, you mentioned the trust is relative. It's always relative to the utility that you have. And there was recently a rating in the newspaper where when you ask people who use Facebook or WhatsApp how they trust it, they rate it as high as Migros, which is a retail chain in Switzerland, which is known for very high trust. Why? Because they say, I use it all the time. I have to trust it, sort of. But it is the utility that makes you trust it. And the way we cannot implement electronic health records in Switzerland or in Germany or in the Netherlands like they've done in Denmark is because nowadays there are so many opposing forces, media that uncover any flaws, physicians who fear transparency and all these kind of things, and extra work, of course. And there is no utility for the individual. And there is no secondary use of the data. The electronic health records in Switzerland would be only here for the primary use, so to have the more efficient exchange. But you cannot do secondary use. And that's where utility is for research, but it's also utility for financial rewards. There is a huge amount of money that can be made on a fair way, so that citizens and the healthcare system as a whole provides if the data is made available in an anonymized form. And we have not been able to do that. Just today in the Financial Times there is an article about the NHS who is now wants to make 55 million patients' record available in anonymized form for secondary use. And they give the patients until June 23rd to opt out of this. And now there's a big media uproar that this is not enough, people don't know what it means, etc., and so on. So you cannot do it this way. NHS has tried many times. You cannot do it this way. You have to do it from the individual. Not everyone had a smartphone at the beginning, so some were first, then the others came, and so it spreads. You cannot do it from top down. You have to do it from bottom up, and for that you have to create iPhone moments or killer apps that help you to solve your problem.
Yeah, maybe I could also add my experience on that, because I'm really jealous of Sean and his brain health data bank. We were in contact, we worked really closely with a hospital here in Zurich. And we also saw they have to like store the data out of law issues for at least 20 years. So all like EEG files, imaging files, all medication and all these information is stored there. On magnetic tapes, and no one is using it. And when we saw it, it was really like, there's so much knowledge there. It's a treasure lying there around, and actually no one can use it. So we were having like a similar idea, getting these data out, having it anonymized, really having it in a clear way, clean way, and then really have high quality data that could for I don't know, epilepsy diagnosis could be really useful, or seeing what kind of medication has what kind of effects. And so we were in close contact with the like who's in charge of the hospital, and they were just really afraid. So they all said it's a really good idea, but actually we are not going to do this. We don't give you the data. But when we saw like, okay, let's have a look how many of the patient actually got a consent ready that we could use these data for research, it was more than like 70%. So the patients were really like, sure, if you can do something with the data and it's anonymized and it's not my name written somewhere, we are totally fine that something useful is done with it. But yeah, we are still like struggling to find a way to open this data now for research purposes, or to make it available. And I think what we can learn from Sean's brain health data bank is really, okay, if you put like a research project around, have a defined purpose for the data, I think it's an approach to get the clinics also in Switzerland to really think about what can actually be done with this data.
Thanks, Teresa, also for sharing your insights. Sean, is the Canadian healthcare system more trustworthy, or the patients more generous, or how do you explain that difference?
I don't think there's any magic to the Canadian health system. I think it is a universal healthcare system, but in many ways Canada, I think is very conservative about data sharing and about. Certainly, we also have a federated structure in Canada where it's quite hard to move data across the provinces. That there's different regulatory laws for data in different provinces. So it's quite a hassle to kind of think about how do you adhere to all of those different restrictions. I think that the key for us is we've been really focused in on how can we benefit patient care? How can we benefit clinician workflows? And how can we provide something of value to patients? And when you make that argument, one of the key things that any ethics board has to weigh is the benefit versus the risk. And I think what is too often ignored is the benefit. The risk is amplified, particularly because of fear of digital and hacks and who knows what, because people aren't necessarily comfortable knowing for sure what is the possibility, and at the same time, the potential benefit is not really clear. And I think by making it very clear, we can provide a decision support dashboard to clinicians that compares the individual trajectories of a patient to the history of patients that we've had in a clinic, right? Right away, we can provide value to clinicians, and it's giving them a purpose to entering in this data into the EHR, because normally when they enter it in, it goes into this black hole, which it's really hard to get back out again, and they don't really know why they're doing this. But if you can bring it out and you can visualize it, you can show it to them, and it can be relevant to treating their patient, well, that's really useful, right? So co-design with the patients, actually. They want to see their data too. They want to see how are they doing. Obviously, you don't want to create panic by saying, oh, look, you're not doing well, but you want to provide support. You want to provide data that can help reinforce adherence to a treatment or reinforce coming in and getting additional help when you need it. And that co-design brings forward all of those issues, and it brings with it trust, because they understand what, clinicians, if they don't know where the data is coming from, that a machine learning algorithm is working off of, they're not going to trust it. But if they're part of the process, if they're part of generating and using that, and the same with patients, I think it requires that collaboration. It requires that combination of trust and value together.
Mm. I think what you said brings me to another theme. It's the incentive system. And if we succeed in showcasing the benefits for everybody involved, I think then the incentive system, I'm not only talking about the financial incentive system, becomes much more obvious. And, I talked also in my past to many physicians, and some of them told me, it's just additional work in addition to what I have to do in my daily routine, treating patients, doing research, whatever. I also have to implement new technologies and have to read through lengthy files about the software and so forth. So the incentive system is, first of all, in my view, not in place yet. But what you described, Sean, could definitely help. Maybe, Thomas, could you elaborate a bit? How do you perceive this, and what do you think about the incentive system, financial and other ones, in the clinic?
Yeah, well, as I said, everybody who participates in such a process should immediately have some benefits. And when I was still the medical director of the epilepsy clinic, we tried to use new technology, at least that was our goal, to use new technology to communicate with the referrers. For example, if we help them treat their patients by analyzing together with them the EEG recordings they make, they can provide better health care to their patients, but eventually the benefit for the hospital is that they might send us the really difficult cases that I cannot treat as outpatients any longer. That, of course, is necessary for every hospital that concentrates on the treatment of chronic diseases, because we do not have any case mixes, and we have to think, how do we fill our beds with patients who can use our knowledge and our help? So we have the benefit because we get more patients, more referrers. The clinician, the physicians in their private practices have the benefit because they can use our knowledge to treat their patients, and they can show this to their patients as well. They have direct contact to the experts. So they have benefit as well. And the patient, of course, eventually also has benefits because he gets better treatment. Of course, you cannot try to have a system that solves all the problems immediately. That has been promised so often and again, and nobody believes it anymore. But if you can show there certain problems, for example, in the interpretation of the video recordings of a seizure and of the EEG recording of a patient, and we are going to help you to solve these problems. And these are concrete problems that can be solved, and everybody profits from it. And I think we should find such solutions that we can make work, and eventually I think we can pave the way to larger systems.
Mm-hmm. I would turn our focus now a little bit to more the technological side, because what I hear often is, the interoperability is not given. It's very, very difficult. For For example, at the University Hospital in Zurich, a few years back, they used 40 different softwares for data storage and processing within one hospital. Teresa, how do you perceive this problem, and how do you see the future of this interoperability? Also knowing that in Switzerland on a national level we have a huge effort to make the Swiss data interoperable, but even that seems to be almost a mission impossible. How is your perspective for the future?
It's really a nightmare. So especially what Sean also mentioned, if you try to have like a good quality case where you have all the information available, you have to go to like 10, 15 different storing systems and clinic systems to get the name, to get the, like, what's the diagnosis, where is the EG data, where is the imaging data, so it's really a nightmare because there are too many bits and pieces. It, of course, can be solved. It's just really like labor intensive. And I think if you can solve it in one clinic, you can just go to the next. I mean, it's everywhere, I guess, the same. But yeah, that's also not the only problem. There's also the highly regulation of a clinic, and this is, you have to discuss it with the people actually using the software. Let's say the physician or the clinician. You have the CEO who's in charge of, or he or she is in charge of making the decisions. You have the IT, and they have something else to tell you when you come up with a new solution, a new digital solution. And I think that's really like a tricky landscape to connect all these bits and pieces. And to have a killing software is one thing, but to actually get everyone involved and get it actually implemented there in this environment, this is like it's the tricky part actually.
Mm. Would you think we would ever succeed also taking into account that technology moves so fast forward in this area? We discussed before a little bit with Ernst Haven, already having a disk player is now not the standard anymore. So this is a technology a few years back, but nobody uses it today. Or are we constantly lagging behind? How would you perceive this question to everybody?
Well, I think there is no two ways about it. We have to move, because if we don't move, Amazon moves and Google moves. And Amazon Health has already announced that for its 1 million employees, it will just provide health insurance, which will be cheaper or actually free for the members, providing that they give all their data to Amazon. Amazon will make the data interoperable. They will use FHIR as a standard. They will use SNOMED. They will capitalize on the data. They will make the data useful also for better health. And if we don't move, then Amazon Health is going to come to Switzerland and will offer a health insurance that's half the price of the health insurance we pay here. And then we're even more dependent on them. So I think it's very clear that we have to move in a way that we're not falling prey only to the American surveillance capitalism model, but not to the Chinese state surveillance model, but that we find a way that we make it possible that we actually, as individuals, and also as healthy individuals, not only as patients, because our healthcare system is a sick care system, and we want to actually stay healthy. So we and our health insurance have actually the aim to keep us healthy, because that's when they make the most money. So I think we have to definitely move. And the technology is here, FHIR is here, SNOMED is here. We as individuals can decide on the secondary usage of the data. If we give it into a sort of data commons that is controlled by the people, then we all benefit as a society.
Mm-hmm. Thank you. Sean, would you add something to that, or?
Yeah, I think this idea that we need citizen engagement, and I think this idea of being able to track not only the illness but also the health, and to get the full trajectory of across one's life as data that can be used to inform when somebody does become ill, but also can serve a global good. I think this idea of a commons of interoperable data that is governed by the individual is a great idea, but that requires breaking down some of these silos, and a commitment to saying, this is for the greater good, this is for the health of the people, that we need to share this data, we need to integrate this data, and we need to make it available under good governance, under proper governance, for improving health treatments and outcomes.
Having that in mind, I think that the word inter is really key, interoperability. We should break down the silos, as you said, between, in Switzerland, the cantons. This federalistic system poses a huge barrier. Every canton, and probably it's the same with the provinces in Canada, wants to develop their own system. So to act more on this inter-level, and also between everybody who is involved, between patients and caregivers. So I think this is really a magic word. Maybe we should focus more on that in the future. Looking at the time, we are already reaching the end of our debate, and to round this up, I asked all of you beforehand if you would be able to deposit a wish towards the government, the hospitals, and the patients. What kind of wish would you have for them? Thomas?
I start. But first, the wish I would like to address to the governments is not to develop new regulations for every new idea how data sharing can be improved, or at least they should ask the patients and all those involved in the work, not only lawyers. Hospitals, I think hospitals have learned that they do not own the data, but now they should also learn that owning their data is not their asset. Their asset is sharing data and sharing knowledge, which also can help to improve the economical problems of the individual hospital. And the wish I would like to address to patients is that they should insist to get a copy of the reports and a copy of the significant data. Not only the normal data of a 72-hour recordings of EEG, but those 3 minutes that recorded epilepsy typical or epileptiform potentials and maybe even a seizure, they should get a copy of this, and they should be able to show it around to everybody they want to. And they should ask Ernst how it is possible to donate their data.
Okay, thank you very much, Ernst. What are your 3 wishes?
Yeah, just picking up on what Thomas said, I think when we were young, our parents around Christmas always bought one of those stickers that they put on their jackets for donating some money to Pro Juventute or something like that, and it actually showed, oh, this guy has done something. So I would like to propose that we have a data donation sticker, that we actually buy into having someone, not myself, collecting all the data, making it interoperable according to the rules that are there, and then donating this into a data commons, and that we see that whenever we walk out. It's as simple as that, and then maybe that will take on, because if we get something out of it, then it is beneficial for all of us.
Thank you, Sean. Do you have?
I think it's so important that the government see the opportunity and the benefit, and not only the risk. I think Switzerland has a chance. It's small but diverse. It's got the ability to make a powerful change, but it needs to make that decision that for the benefit of the commons, of the good, of the people, this data should be used for improving care. Hospitals should be part of that picture. I think, just as Thomas was saying, I think recognizing not only is this not necessarily the hospital's data, but this belongs to improving health care. It belongs to the people. And for the patients, I think we've always talked about patients and advocacy for patients, and patients being, having a voice and having an ability to get better care through advocacy. But I think, by being empowered with their own data, by being empowered to understand the decisions that are being made, because they are also involved in owning their data and seeing their data, that they're engaged in their own recovery, that they're engaged in their own maintenance of health, suddenly changes the equation. And I think there's tremendous economic benefits. I think there's tremendous societal benefits, and I think there's tremendous individual benefits for good long life.
Thanks, Sean. And lady last, Teresa, please.
I think, yeah, for the government, I mean, regulation always is lagging behind technology. So I think we can't wish for like getting everything ready as soon as we come up with a new idea. But maybe, also help companies that have good ideas and not just like put stones in the way, but really try to help them and get their ideas out there. And I think for the patient, what we heard already, I think everyone should understand what kind of treasure we all own, our own health data. And for the hospitals, I mean, I'm now talking as a tech company. Everyone should hop on board and use our platform, and then maybe really use it as a tool to enhance the collaboration between them.
Okay, thanks a lot. This was a very nice, meaningful wish list. And to end off, I mean, we all hope that this COVID-19 situation, which we didn't touch at all today, is kind of boosting this digitization of the healthcare system in a responsible way, taking care of the autonomy of the patients, but also of privacy issues, which we all consider to be very important. But I think what we really learned today from all of you, the importance of including everybody involved from very early stage on, having this generous view about the opportunities and not only the risks. And then in the end, also every single partner can profit in the long run. And I think definitely this perspective of the benefits of what we can gain and not always this fear of what we can lose. This is really, in my view, one of the keys for success. So let's hope that your wishes come true. Part of them are. And I think all what you presented, it's excellent steps in the right direction. So let's hope we can then in 20 years have another question in the theme of a debate. Thanks a lot to excellent, stimulating panelists, Sean Hill from Canada, Thomas Grunwald, Teresa Solfrank, and Ernst Haven. I'd like to conclude the debate for today. Thanks for listening and see you another time. Bye.